Lupus Live. My name is Chris Wincup. I'm a research fellow here at UCL.
My name is David Isenberg, and I'm the Academic Director of Adult Rheumatology and Co-Director of the National Adolescent Arthritis Unit, also here at University College London.
Thank you very much for sending in so many questions. One of the most common questions that we had is, what is lupus? I think you're probably the best person to give an answer on this one.
Well, lupus is usually classified or defined according to some criteria, and there are two major sets of criteria, and it's usually a combination of clinical features and blood test abnormalities which helps to come to the diagnosis. I should say that it's not that common a disease. In the United Kingdom, there are probably no more than about 25 to 30,000 lupus patients in all, and in the United States, with a population perhaps 6 times as many as in the UK, the numbers are around 250,000 to 350,000. So we think of lupus as a disease in which the immune system, which is really there to protect us, begins to take aim at ourselves, at our own bodies, a form of friendly fire, if you like. And it presents in a number of different ways. Perhaps one of the commonest is a rash, often seen on the face in the areas which can be affected by light, a so-called photosensitive rash. And this rash is often accompanied by a form of arthritis. And these features are invariably found in women between the ages of 15 and 50, and 90% of patients with lupus are women. But in addition to the skin and the joints, lupus patients may also have inflammation affecting the lungs, the heart, particularly the kidneys, which is very worrying, and the central nervous system, including the brain, obviously. It can much less frequently affect the gut, and very, very rarely it can affect the eye. But it really is a systemic disease caused by this process of friendly fire and giving rise to a whole host of clinical manifestations and some very particular blood test abnormalities, which I'm sure we'll come back to in the course of our discussion, Chris.
So one of the other questions that we've been asked is with regards to how lupus is often diagnosed and in some cases misdiagnosed. Now, as we've already discussed, some of the symptoms of lupus can be very generalised, and it can be difficult for doctors and for patients to pick up the diagnosis and put the symptoms together to come up with a diagnosis of lupus. We know from studies in the UK that patients can often wait a long period of time for a diagnosis. In some cases, it's been suggested as over 7 years for the diagnosis to be made from the onset of the first symptoms. And as we've mentioned, some of these symptoms can be very generalised to start off with, making it a challenge. So one of the important things about Lupus Awareness Month is spreading this awareness both to patients and to clinicians so that this diagnosis is picked up sooner and treatment is started in a more timely fashion.
That's absolutely right. And of course, the other problem is that lupus is known as the great mimic because it could look like so many other different conditions. And one of the classic examples is patients who have another friendly fire disease called rheumatoid arthritis. This also is more common in women, though often slightly an older patient group. But the sort of joints which are involved is often the same in both groups of patients. In other words, it's the small joints. So the small joints in the hands, the knuckle joints, for example, and the finger joints can be affected. But there are many other diseases which can mimic lupus. So, for example, some lupus patients present with epilepsy, which may occur just as a thing on its own, kind of primary epilepsy, if you like, or it may be the presenting feature of patients with lupus. And another condition presents with low platelet cells. These cells are very important because they enable the clotting of the blood. And in some people, unfortunate enough, they get the low platelets but nothing else, and that's all they'll ever have. But in other patients, the low platelet presentation is followed often some months or years later with other more classic features of lupus. So lupus is the great mimic, and general practitioners and hospital doctors have to be very much aware of the fact that lupus can look like so many other different conditions.
I think it's a very interesting point about important blood tests in lupus, and certainly some of the questions that we've had here are based upon what blood tests might be done in the context of a patient with suspected lupus. Now we know one of the key blood tests is the ANA or anti-nuclear antibody test, which is seen in the overwhelming majority of patients with lupus. Now, some doctors may decide to do this test if suspecting a case of lupus, in which case it can be very helpful in bringing this to their attention and confirming a diagnosis or prompting them to make a referral to a rheumatologist for an opinion. However, this blood test can be positive in a number of different conditions that have been discussed, and I see from the questions we've been asked here, conditions like Sjogren's syndrome and other forms of arthritis can have this blood test positive. But it's also important to remember that in some cases this can be positive at very low levels in people who are otherwise well and healthy. So it is important that doctors consider this blood test, but also put it together with the clinical symptoms that the patient's describing.
Yeah, I think Chris makes a very important point. It's not just the positivity, but the, if you like, the height or the amount of the anti-nuclear antibody. It's done by what's called a dilution technique. And in lupus patients, the level really ought to be 1 in 80, the dilution, or even 1 in 160 or higher. Often it's 1 in several thousands, whereas quite a number of even healthy people after infections can develop a very low level of anti-nuclear antibody. It's been estimated, just we should perhaps add, that perhaps 2 to 4% of patients with lupus who meet the classification criteria are anti-nuclear antibody negative. That does occur, but I want to emphasize that's very unusual, and in those sort of patients, we suspect that there are other antibodies detectable in the blood which are binding to antigens or targets which are present just outside the nucleus of the cell, in this part of the cell that's known as the cytoplasm. So one of the components of the cytoplasm is a protein known as Rho or RO, and in some lupus patients, even though their anti-nuclear antibody is negative, they're positive for the anti-Rho antibody. And that, in the presence of other clinical features of lupus, is on occasion enough to make the diagnosis of lupus, but I emphasize that these patients are very much in the minority.
One of the interesting questions we've been asked here is regard to the involvement of lupus in the brain, and the question is there a difference between cerebral lupus and neuropsychiatric lupus, which are two terms that are very commonly used to describe when lupus affects the brain. Now, this can present in a variety of different ways with a lot of different symptoms, and can be very difficult to pick up even in someone who's known to have lupus. The important thing to say about these terms is this involves any part of the nervous system or brain that's involved with active lupus. When a clinician is suspecting this, it's important that lupus specialists are involved, in addition to neurologists and in some cases psychiatrists, to help look at these symptoms and decide whether this is related to the underlying lupus. I know you've previously spoken about neuropsychiatric lupus and its treatment.
So perhaps nowhere is lupus more variable in the way that it can affect parts of the body than in the brain, where literally everything from migraine to madness may be a feature of lupus. It's a little bit confusing because certainly the American College of Rheumatology, when they set out their classification criteria for lupus, said there were only 2 features which constituted cerebral involvement in lupus. One was seizures, one was psychosis. But then the same august institution had a working party, and I have to confess I was part of that working party, which said it's not 2, it's up to 19 different syndromes, 12 in the brain and 7 more peripherally. So there's a certain element of you can decide to go with whichever one you believe. By and large, I think it would be true to say that somewhere between 20 and 40% of lupus patients develop features which could be ascribed to the brain and to a lesser extent the peripheral nervous system being involved. But Chris, perhaps we should turn to the other thorny issue, which is often raised, of whether or not lupus patients can get things like fibromyalgia and ME and so-called functional disorders like irritable bowel syndrome. Now, we had an interest here in fibromyalgia some years ago. So fibromyalgia certainly used to be diagnosed on the basis of a history of chronic pain and together with some pressure point tenderness in certain parts of the body. And we estimated in our group of patients that around 5 to 10% of lupus patients in the UK could be co-diagnosed as having fibromyalgia and lupus. In the United States, that number is 2 to 3 times higher. And whether this is because lupus patients in the UK are slightly more stoic or if there's some other reason, we just don't know for sure. But it's certainly possible to have lupus and, if you like, a chronic pain problem, and we certainly do see that. And just en passant, it's worthwhile mentioning that about 4% of lupus patients have hypermobile joints. They're bendy joints, if you like. So people can be very bendy in their joints, they can be hypermobile, and that can occur to a lupus patient as it can to any other human being.
I think in addition to the chronic pain and fibromyalgia angle, it's important to think about fatigue, and this is an area that I've looked into in some detail here in our cohort of patients and with other cohorts around the world. We know that fatigue is a big problem for patients with lupus, affecting between 80 to 90% of patients. In fact, that number of patients often say that fatigue is their most troublesome symptom, which puts this as a very high problem with a large burden. Interestingly, from the studies that we've done here, it doesn't appear to obviously correlate with how active someone's lupus is. So you can have very well-controlled lupus with otherwise normal blood tests and still be troubled by very high levels of fatigue. Furthermore, in terms of increasing the immunosuppressive treatment that we may use in lupus, there's nothing that reliably says that this can improve fatigue symptoms. And this symptom remains a large mystery in the context of patients with lupus and is very poorly understood.
Now, one of the questions we've been asked is why so many doctors, I think the question implies general practitioners, don't know much about lupus. And I think it's a numbers thing, really. Remember, the population of the UK is something in excess of 60 million people, and yet there are only around 25,000 lupus patients. So what that means in practice is that there will be many general practitioners who may not have more than one or two lupus patients in their practice, and they may see no more than a very small number of patients in their entire career. So they just don't see it very often. And I think that's principally why many general practitioners simply don't know a vast amount about it. I think most general practitioners, once they are made aware that the diagnosis is lupus, or if they make that diagnosis themselves, will invariably pass that patient on to the hospital doctors. So that although there may be an element of shared care in the management of lupus, it's also true that it's the hospital doctors who bear the brunt of looking after the patients. I think that's why general practitioners on the whole are not going to know a vast amount about it. But I think these days with the internet, I think most general practitioners also accept the fact lupus patients, given the diagnosis, are going to go straight to the internet to look up features of this disease. And the slightly concerning aspect of that is that very often patients with lupus like to tell their stories on the internet if they've had a bad experience. And a lot of lupus patients can be managed with relatively modest amounts of medication and managed very successfully. And certainly mine, when I see a lupus patient, is to get them back to the workplace on the smallest amount of drugs that can possibly be, although of course that may be challenging in some cases.
One of the other questions that we have here, and I'm paraphrasing slightly, is with regards to lupus and pregnancy, and in particular with regards to miscarriages. Now, the vast majority of patients, as we've already discussed, who come to lupus clinics are typically young women, so pregnancy is something that is often thought about in clinic. It's important that if you are a patient with lupus and you're thinking about becoming pregnant, that this is a discussion that you have early in the planning stage with your rheumatologist so that they can make sure that the various treatment that you're on is safe for this. Typically, we hope for patients to be very well controlled without any major flare in the recent past before they do decide to start a family. In particular, with regards to this question of miscarriages, we know that lupus can sometimes coexist with the so-called antiphospholipid syndrome, which is a condition characterized by recurrent pregnancy losses and blood clots. This is a condition that doesn't affect all patients with lupus, but is something that's important to be screened in any patient with lupus who's thinking about becoming pregnant. And as I mentioned, it's important that you talk about this very early with your rheumatologist so all of the blood tests can be done and you can be put on medication that is safe during pregnancy.
Actually, Chris, going back to one of the antibodies that I mentioned before, the anti-Rho antibody, this is a very important antibody because it is associated with two particular types of lupus. One is the photosensitive rash, and one is the possibility, or the increased risk, I should say, of a lupus patient giving birth to a child with a so-called neonatal lupus syndrome. That means that the child is born with a rash, which is temporary, but also may have a problem with what's called the electrical conducting system in the heart. Now, the heart has four chambers, the two upper chambers and the two lower chambers, and they beat in a very synchronized sort of way. And in children who are born with this defect, that synchronicity between the two upper chambers and the lower chambers is lost. And that means, especially if the child gets older, and needs to increase the amount of blood that's being pumped out of the heart. It can't do it because the heart isn't functioning properly. And about 2% of mothers who have the anti-Rho antibody will give rise or give birth to children who have this problem. Amazingly, it can be detected in the fetus in just 21 or 22 weeks, so that you will actually know when you give birth to a child whether or not they're going to have this syndrome. But I want to turn back to the question of the central nervous system and lupus, because we've been asked a couple of questions in addition. One is whether or not lupus patients can have a condition called trigeminal neuralgia. That's a very painful condition where shooting pains go across the face, and that is not actually associated with lupus, so it's one of the relatively few things which doesn't have a strong connection. We've also been asked about Raynaud's phenomenon. Now, Raynaud's phenomenon, not surprisingly, was named after a Frenchman called Maurice Raynaud, and he described this about 180 years ago, and he described a very particular thing. It's a colour change in the hands which go to white, to blue, and to red. And this may occur when an individual moves from a hot room to a cold room, and in about 20% of cases with emotion. So when you're very emotional, the hands may go through the same colour change. This is incredibly common, and in probably 99% of cases it has nothing to do with lupus. But in about 1% of those individuals with Raynaud's, if you test the anti-nuclear antibody, you'll find that it's very strongly positive. And it's been estimated that around a third of patients with lupus have this Raynaud's phenomenon.
One of the key questions that comes up throughout this is medication, and in particular one of the drugs that's used most commonly and mentioned most commonly in the questions here is a drug called hydroxychloroquine, which is a drug that we use very frequently in the management of patients with lupus. This is, or was originally, a drug used in the treatment of malaria, but has been found to be useful in a number of autoimmune conditions such as lupus and arthritis. This is typically a very well tolerated medicine and is often seen as a more mild treatment. It's good for patients who have perhaps more mild symptoms with lupus, including joint pains, rashes and hair loss. But we also know that for all patients with lupus, studies suggest this conveys a good benefit over a long period of time, even if you have the more severe forms of the disease. So this is something that many patients with lupus will often be taking.
I wanted to turn to the question of research, because we've been asked a question which I had to say made me smile a little bit, as to whether the charity that's now called Versus Arthritis, that used to be called Arthritis Research UK, whether they are funding the right people, the right research. Well, I can tell you that if you get a grant that's funded, you think that they're definitely funding the right people. If your grant is turned down, then you make the assumption that it's the wrong people who are being funded. But to be serious about that, I think there has been a sea change in the sort of funding that Versus Arthritis is now giving out. I think it's become much more aware, the charity that is, of the importance of translational funding and more directly trying to support clinical work, if you like. It has a very strong bias, and I think that's absolutely appropriate, to basic science research, because it's really only by understanding or getting a better understanding of the way that the disease is brought about that we're really going to move to more precise treatment. I think it's probably important to say that lupus is probably not a single, simple, homogeneous disease. I think there are a number of overlapping conditions, and I think we can be very sure about that. I'll give you some examples. So last Monday in my lupus clinic, the first patient who came in was Caucasian. She had a history of a photosensitive rash. She had some joint pain, she had an anti-nuclear antibody, and she had an antibody called SM, and she met the criteria for lupus. She'd only ever been treated with a drug called hydroxychloroquine for a number of years, and she was doing pretty well. The second patient who came originally from Nigeria, though she'd lived in England for many years, and she had terrible disease in her kidneys, lupus nephritis, very little else, though she does have antibodies to DNA, anti-nuclear antibodies, and at one point had a very low platelet count. And she too met the criteria for lupus. And the third patient that I saw came from Bangladesh, and she had a story of inflammation of the lungs and the heart, giving rise to a condition that we call pleuritis and pericarditis, causing shortness of breath and pain when taking a deep breath in. And she too had an anti-nuclear antibody, and she had some other autoantibodies which are pretty typical of lupus, and she'd had some previous joint pains too. So when you hear these three very distinct histories, it's very hard to believe that these are all exactly the same disease, and I'm sure they're not actually. But I think as human beings, we tend to form into two groups, the so-called lumpers or the splitters. And so lupus, if you like, is an example of the lumpers at work, where we try to put together a number of patients who have some clinical features and some blood test abnormalities in common, but it's far from homogeneous. And I think it's very likely, in fact certain, that the way that we approach individual patients, the way we treat them, has to vary according to the individual. We're moving much more to an era of personalised medicine, and I think that's reflected. And Chris, you might want to comment on this other question that we've had about general treatment for lupus, what drugs are available.
Yeah, so as we mentioned, hydroxychloroquine is one of the drugs that's commonly used. Steroids are a drug that's been around for a very long time, drugs like prednisolone, and these can be incredibly useful in short periods to settle down acute symptoms of lupus, and in particular if you're very unwell, these can be given as an intravenous drip to rapidly try and settle down symptoms. However, we like to make sure that these doses are then reduced, and if patients are unable to come off them in the long term, that we keep these at quite low doses. So hydroxychloroquine and prednisolone are two very common treatments. The next set of treatments are what we call immunosuppressive medicine, and as was mentioned at the beginning, lupus is an autoimmune disease where the immune system is overactive, and so the next set of treatment is there to lower the body's immune system down, and these include drugs like mycophenolate and azathioprine, which are commonly used in slightly more severe cases of lupus. We then have a newer category of drugs that is recently being developed. These drugs can be given as infusions. We have rituximab, which is an intravenous infusion that clears the B cells that causes the lupus, and this can be a very effective treatment that has been shown to be beneficial in a wide variety of symptoms from lupus. And we now have a newer drug that's recently been licensed and is one of the first licensed drugs for lupus in many, many years, a drug called belimumab that affects what we know is the BAFF levels within the body. So this is a chemical that signals to make B cells active in the blood, and this is a drug that's very recently been developed and is now finding its place in terms of where we treat patients with lupus.
I'd like to turn now to the question of when lupus starts, and another question which linked this to gender. The question is, could it be that gender bias contributes to the very long average time to SLE diagnosis, given the mean age at diagnosis is 48.9 years? And I'm going to be slightly controversial and say that I profoundly disagree with that statement. I think I know where it comes from. There was a GP-based study which made a claim that the average age of onset of lupus was indeed in the late 40s. That is absolutely not my experience. Here at University College Hospital, we've seen in the last 35 years 715 patients for long-term follow-up. The average age of onset was 27 years, and that's very close to a figure up at the University of Birmingham, which again has around 500 patients. So I'm not quite certain how this GP figure was arrived at. I suspect that a number of lupus patients actually had the disease for quite a long time before they were counted as having lupus. But do I think that gender bias contributes to the very long average time? I don't think so. I think that, as I've said, 90% of patients with lupus are female. And I think that the issue in terms of making the diagnosis of lupus is thinking of the diagnosis. And if you think certainly in younger women in their 20s and 30s who present with joint pains, with rashes, with low platelets, with recurrent cross mouth ulcers, for example, with pleurisy, the important thing is for the GP or the hospital physician to think about lupus as a possible diagnosis, because in terms of the blood test, it's pretty easy in many cases to actually make that diagnosis a very firm and solid one.
One of the interesting questions we've had here is with regards to the relationship between lupus and a high blood pressure and raised cholesterol. Now, certainly blood pressure is something that we monitor regularly for patients coming to our lupus clinic here. Cholesterol is something, again, that we do monitor regularly, and these tests are very important as we know that patients with lupus, like many other autoimmune diseases, can be at increased risk of atherosclerosis, and by that I mean conditions that affect the blood vessels may lead to things like strokes and heart attacks. We do know that there is an increased risk in patients with lupus, although it's difficult to tell exactly why that is. In terms of medication, we know that treatment with very high doses of steroids over prolonged periods of time can cause problems here, and so it's important that your doctor is regularly addressing any possible risks that may increase your chances of developing something like heart disease or a stroke. This question in particular said, is my lupus causing my high blood pressure? Now, again, one of the reasons why we like to monitor blood pressure in the lupus clinic is we know that when lupus affects the kidney, it is absolutely essential that the blood pressure is well monitored and well controlled to prevent any further damage to the kidney. And sometimes elevated blood pressure may be a telltale sign that there is involvement within the kidney there.
There's been some concern expressed, again this gets back to the question of GPs and the diagnosis, and one of our questioners says that I was diagnosed with lupus based on 3 blood tests and a rash. The rheumatologist did a count of his notes and said, yes, you've got 4 features, and you can certainly imagine a general practitioner doing this as well, and just saying you've got lupus. I think that's what the diagnosis is. Go away and read about it. And the question is that a good way to explain it? And of course the answer is absolutely not. And it's important, I think, to get context right, and it's important to be realistic about what lupus is likely to mean. Now, an important point to make here is that it is, in my experience, often 3 to 5 years before the full flavour, if you like, of the individual lupus in a given patient is really going to declare itself. And that particularly applies to kidney lupus, renal lupus, which may be 2, 3, 4, 5 years before it really becomes self-evident. And very rarely it can occur after even longer periods. In this last 4 or 5 years, we've seen, for example, 3 patients who had lupus for 15 years before they finally got the lupus nephritis. But it's very important, because lupus can be sinister, it can be serious, that you have to explain to patients that it is an important and to some extent concerning disease. But, and I think this is an important but, given proper care, given proper treatment, given proper follow-up, given access to appropriate specialists, it is certainly possible to treat this condition and to treat it pretty effectively. And we've got much better at it. If you were diagnosed with lupus in 1950, there was a 1 in 2 chance you'd be dead within 4 years, which is pretty scary. Nowadays, the figure is about 85%, 15 years survival. So you can see there's been an enormous improvement. That's the good side of this equation. The bad side is, if you looked at the patients in our cohort who died, it's about 15% of them, the average age of death of those patients was 47 years. The average age of death in a woman is 80 years. So for a small but significant number of lupus patients, death continues to come too soon, which is why it's very, very important, once the diagnosis is seriously considered or made, that as a patient you get referred to a lupus centre. And up and down the UK we have, I think, with the British Isles Lupus Group, the BILAG, and there are about 17 or 18 different BILAG centres all over the UK, and you're strongly recommended to go and see colleagues in one of those BILAG centres, and or to go and see a competent consultant rheumatologist locally if that's sort of easy for you to do.
So through the wonders of modern technology, I think we're having some questions actually being sent through to us while we're live here. So one of those questions that I've just been handed is, can lupus be cured, or is it more something that you have to deal with over a long period of time? So first of all, thank you very much for your question. In terms of a cure for lupus, for example, a treatment that will stop the disease and get rid of it, unfortunately that's not something that we currently have available. So it is more the latter, where the symptoms are managed and regular review is required to see how active the disease is, and the treatment is very much based on trying to ensure that the symptoms are well controlled. However, as an illness, we know that it can flare up and settle over time, and so this is why we need to ensure that patients are regularly seen by specialists who have experience in this area, as they'll be able to pick up any possible signs on blood tests, possibly before the symptoms even develop, and arrange for treatment to be started at the correct time. So unfortunately at the moment there is no cure. There is, however, ways of managing the symptoms and bringing things under control, which means that the vast majority of patients do have to go on to long-term treatment and have regular follow-up with their rheumatologist.
I agree with that, although there's one small, slightly more hopeful caveat. We've looked very recently at the very long-term outcome of our patients. So we've had 715 over the last 35 years. And what we showed was that if you define complete remission as patients having no clinical features due to lupus, together with no evidence on the blood test of lupus activity, and they've managed to get rid of the steroids that they were on and the immunosuppressive drugs that they were on, we found that about 14% of patients that we'd seen had a remission which lasted 3 years in that context. But unfortunately, at least 1 in 5 of those patients, even after 3 years when the disease did seem genuinely to have gone away, it came back again. So it's very hard with lupus to say that it's all over. And I've even seen flares in patients with lupus in their 60s and very, very rare in their 70s. So it is a disease which you have to continue to monitor for decades, literally. And I think we talk more in terms of control rather than cure for most patients with lupus.
I think that's all of the questions that we've been asked to cover today. So I'd just like to say thank you very much to everyone who was involved, everyone who submitted a question, and anyone that's done anything to be involved in Lupus Awareness Month. Thank you to Professor Isenberg and to everyone else who's helped set up this live stream today.
Thanks for coming to join us.